Welcome to the Heads Up podcast, brought to you by the National Migraine Centre, the only UK charity treating headache and migraine. Visit our website to book your appointment with a world-class headache doctor wherever you are in the UK. There is no need for a referral. You can refer yourself. Our headache specialist doctors are looking forward to helping you soon.
Hello everybody and welcome back to this episode of Heads Up Podcast. And today we are going to be talking about a topic which I'm hoping is going to be useful to a lot of people who are trying to get some help to manage their headache or migraine or cluster headache or whatever. So we're going to be talking first of all about how to prepare for an appointment with your healthcare professional, and then we're going to also go on to discussing what might be the problems or the difficulties that you face and how we can get around these. And we're talking around health inequalities in terms of race or gender, and also accessibility to some of the treatments that we now have available. So I'm very delighted to welcome two of my lovely colleagues from the National Migraine Centre who are both feeling very passionate about the topics for today. So I'm going to let them introduce themselves. Surangi, would you like to start?
Hello everyone, my name is Dr Surangi Mendis. As Katy mentioned, I am one of the clinicians at the National Migraine Centre, so I see patients with headache and migraine, but in my NHS role I work as a dizziness specialist in a central London teaching hospital within the NHS.
And Lauren, would you introduce yourself?
Thank you. Yeah, so my name is Dr Wellburn. I'm a clinician with the National Migraine Centre, and then I also have two NHS roles, one as a general salaried GP in the north in Leeds, and also I work as a GP with extended role in headache or a specialist interest in headache within a community neurology service as well.
That's brilliant. And what I'd also like to add is that all three of us are very passionate about spreading education about the headache conditions, raising awareness, and really getting out there. So I know Lauren and Surangi both go and do lectures and talks to virtually anybody that will listen, which is a bit like me too, just to try and raise awareness about these really disabling conditions. So we're going to talk about getting the most out of your healthcare practitioner appointments. And I wanted to just start off by saying, of course, what is a healthcare practitioner? That's a bit of a mouthful. But we know from our experience of listening to patients that sometimes people have gone to a wide range of different people before they get to see us. So that might be an optician, it might be the pharmacist, it might be they might have been referred to an ear, nose and throat specialist because they've had dizziness or sinusitis symptoms, and that turns out to be migraine. They might have seen practice nurses or GPs with a special interest, or then got through to general neurologists or to more specialist neurologists. So there's a wide range of people that we could talk about. I mean, the list is pretty endless, really. I mustn't miss out osteopaths, physiotherapists, chiropractors. You know, people have a number of presentations with their migraine, and so they seek help in various different places. But what we're going to talk today about is, if you're going for your first appointment, how to prepare for that, and assuming that this is probably within a general practice, or maybe you've been referred to secondary care and you're seeing a neurologist. So what is going to be helpful, and what do you need to do to get the most out of that appointment? Because we know that time is a precious commodity, and the more prepared you can be, I would say the more useful that will be, both for you to get your message across, but also for the clinician who's seeing you to know what your priorities are. So Lauren, would you like to sort of start to explain what you think people should be doing?
Yeah, absolutely. I think it's really important ahead of your appointment to just have a sit down with a cup of tea and have a think back over your symptoms, be they the last few months or the last 3 decades. And if you can assimilate all of that information as much as possible onto a piece of paper or some notes on your phone to maybe give the clearest description for yourself, your voice, of the symptoms you've been experiencing, how long you've been experiencing them, how they've changed over time. some of the treatments you might have tried and what's worked, what hasn't. If you can, use your NHS app to see what doses you've been on, for example, why you've stopped them. This can be really useful information to get down, both to show yourself really the journey that you've been on and help you get your voice across to the clinician, but also to really get that information in a succinct way across to your general practitioner or the neurologist you're seeing, so that they can really help you as best they can in the limited time you have available.
You know, you were saying about the past treatments that you've tried. I think that's one of the key things, isn't it, we find helpful. And that is, what is the name of the drug? What was the dose that you got up to? How long were you on that? And why, if you're not still on it, why did you come off it? And one of the reasons for us needing that information is because there are some rules now about access to new medications that say, well, you can only have this new medication if you've tried 3 other preventatives, or depending on what you're asking for, maybe 2 other triptans. So if you can have the names and the doses and the history of that at your fingertips, that's really helpful, isn't it? Because quite often we hear people saying, well, I know I tried one and I think it was, I can't quite remember the name, but your GP should have that information. If you can't find it on your NHS app, you could ask the GP to print out a medication record, and that might be helpful as well.
Absolutely.
Yeah. Anything that you would add, Surangi, to that?
I think the only thing is that on that last point, I mean, that information, even if it was only that part that you were able to almost put in a table and, say, what drug you took, how long for, side effects, if any, the maximum dose reached. Because if you could provide that in advance to the clinician ahead of the appointment, it's almost like we would want to, if I had that, I would transpose that almost directly into the letter. It just cuts out so much of the, it allows the clinician, the patient, to really focus on what they would like to really get out of that consultation, and just, elevates the whole thing. So I think, that's the only thing I would add, really. And anything written in advance that can be provided. Every clinician is different. I think most of us at the National Migraine Centre, we operate in a similar way. We really like to look at in detail what's been sent in advance. And amongst our clinicians WhatsApp group, I know that, sometimes if not much information is sent in advance, that's absolutely fine. We can treat that as a blank slate. But if actually all this, previous consultations, MRI reports, etc., if that's sent in advance, actually we're preparing the letter in advance, because we have that time at the National Migraine Centre, and it's nice to have that information to be able to add to that in the consult.
I think there are a couple of other things regarding medication. I sometimes get patients who say, and I've heard about this one and I definitely don't want to try that because. So I think it's also useful to flag up if you've got a particular concern about a medication, or if you've got a past medical history which contains something like asthma, which means that you shouldn't be taking certain medications. It's important. Hopefully the doctor that you're seeing, or it might be the practice nurse, or it might even be a specialist pharmacist. I know some specialist pharmacists who are very highly skilled in helping people with migraine and headache disorders. And hopefully they'll have access to your past medical history, but they may not. So it is worth flagging, if you have a history of asthma or anxiety, depression, or high blood pressure, or any, neurological conditions that you think, actually, this is relevant. And the other thing I think is there are sometimes along the way significant events that people throw into the conversation. So I often ask about COVID infections. Had they had a COVID infection around the time that their migraine or attacks worsened? Or have they had an operation? Have they needed to take some opioids or something like that? So significant events, if you can prepare that and just kind of remind yourself, that can be useful. What about priorities, Lauren? What would you say people should be doing? Because we're aware that time is a precious commodity, and we have the luxury of having a bit more time at the National Migraine Centre with patients. But in the NHS, it's hard, isn't it?
Yeah, in the day-to-day NHS role, you are seeing patients often back to back in 10 or 15 minutes throughout the day, 25 up to 30 patients maybe. So that ability to sort of sit and assimilate the information gets squeezed slightly. I think a benefit to the new e-consult models and the triaging systems that are coming through, though they have their challenges, is that if patients are able to use those white space boxes to really get across why they're consulting now, what has changed, why are they requesting an appointment today, what are their priorities within those boxes, and there are questions about that. What are you hoping to achieve, or what treatment would you like? That really helps the triaging GPs get you into the right appointment at the right time with the right person as well. So I would say to patients to try not to use those as a sort of tick box minimal exercise where you just write headache. Try to give that information to the GP so they can really make sure that you are in an appropriately timed appointment at the right length with someone who's going to be able to help you.
Yeah. We sometimes ask about the most bothersome symptom in clinic, don't we? And I think it's worth having a think about your most bothersome symptoms so that you can present that to your healthcare practitioner, because we're always talking about headache specialists and migraine and all of that. But of course, the most bothersome symptom can sometimes be dizziness, can't it, Surangi? And you know this from your NHS work as well. Or it might be brain fog, or it might be persistent aura. So you feel that most bothersome symptom is a key thing for people to be presenting?
Absolutely, and as you said, it can dictate, and that's the real, important thing to kind of pick up at the level of at general practice. That information is crucial because it'll dictate. I'm on the other end. I'm in a dizziness clinic already, so the GP's done all the hard work. They've referred appropriately, and by the time they've come to me, I do all the triage, actually, some of the triage for our service, and I have to say the triage, the GP referrals that come through they're spot on, but that's only dependent on the patient also articulating exactly what is the most important symptom. And as you know, with migraine, it's not always, as you say, headache. It could be brain fog, it could be dizziness, it could be so a whole host of other symptoms. So it is really important to articulate exactly what the main issue is clearly. Yeah. And dizziness itself, it's very, very hard to describe. So this is why exactly what Lauren said earlier about actually getting it down in advance. People will often use the word dizzy, but actually I will press and say, well, what do you mean? Is it spinning? Is it lightheadedness? Is it unsteadiness, like being on the ship? So if you can get that ready in advance and have a think about it, it just, again, like I said, enables us to get the most out of the appointment.
I had somebody the other day who was talking about her really bothersome nausea. And I said, oh, does it make you feel sick? And she said, no, it's not really quite like that. I'm never sick. And her understanding of the word nausea was quite a difficult concept for her to explain to me, I think. It was just a sort of general feeling of not quite right and didn't quite have appetite. And so the words we use are very important. And the fact that we are listening carefully to what patients are trying to explain, I think, that's a really key thing, isn't it? The other thing, I suppose, we need to think in advance of the first appointment or any appointment about your goals. What are you going to ask for? Now, that might be that you want a diagnosis, or it might be that you're just really worried that you've got a brain tumor and you want reassurance, or you might want a scan, or it might be that you're about to lose your job and you really need some sort of intervention that you can take back to your employer and say, look, I'm getting help with this, and this is what the doctors are saying and how we're trying to manage it. And so there's all sorts of reasons why people pitch up, isn't there? I quite often see teenagers brought in by their parents, I need you to help now because he's got his GCSEs or his A-levels or whatever in the next few weeks or months. So thinking about the goals of that consultation is quite important. And you might have more than one goal. You might want to kind of put a list of your top 3 priorities, and be prepared to say that quite early on, wouldn't you say, Laura? Because in an NHS practice, if you know at the beginning of the consultation, right, the patient wants to talk about this, this, and this, you might have to say, right, we'll deal with that one, and then bring you back for another one. Would you say that's something that you do?
Yeah, I mean, I do a talk for the flip side of this for our clinicians on getting the most out of their 10-minute headache consultation. And this is really, I guess, about bringing together 2 different people's agendas, isn't it? We want to capture the person with migraine and their voice, and the clinician has an agenda of things they need to do to be a safe clinician. And really, your priorities are super helpful for us to be able to chunk that consultation and meet both of our aims, really. So I may need to take a really detailed history and work out if I need to be doing any urgent investigations, or if this sounds very much like migraine and I'm happy with that and I can give you a diagnosis today. That might be the first consultation, and that might be what we can manage. So if I know that you have got specific worries about scans or brain tumours, if I know that your main concern is around wanting to access a medication that you've read about, it means right at the start, I can set expectations and we can really build that shared plan together. And that might involve me saying, this is what we're likely to achieve today. That's really helpful information. This part I'd like to see you about in a couple of weeks' time, and can you keep a diary? Can you do this for me? And the other part, I think you might benefit from seeing someone else at the practice about. You know, it's not necessarily about cramming everything into one consultation, but your feelings and your expectations are core to any GP consultation, and it's just the same for headache.
Do you both advise people to write things down before they go to an appointment, or does that fill you with dread when you see somebody whipping out a list?
I personally prefer it, because usually quite quickly I will say, oh, can I have a look at that list? And whilst they're talking, I'm scanning it. And as Lauren said, you know, we might change the order slightly, or I might explain exactly why this particular thing that says, you know, I'm concerned about brain tumor or something, we have to order and prioritize. So, and if we get this wrong, if as Lauren mentioned, if my concerns do not match that of the patient's, then the entire consultation can be effectively, not good use of the patient's time effectively. So, we have to get that order correct, I think. And the list is really helpful, because sometimes we don't want the patient also walking out of the consultation feeling like they've missed something off, or some really important parts has not been addressed.
Yeah, I think that's really important, isn't it? For the best will in the world, when we come in front of clinicians, or patients come in front of clinicians, as much as you smile, quite a lot of people freeze and get brain fog in that moment and cannot really pull out the detail that they've probably been rehearsing in their head and thinking about in the lead up to the appointment. So I'm a massive fan of people writing down their key questions, the key things they want to get across to me.
And they can email them to us at the National Migraine Centre in advance of the consultation. It's really helpful to have that, isn't it? Because you start off going, oh, I know why you've come. That's brilliant, really. And I think then the other thing is, at the end of the consultation, is for the clinician to remember to say, and do you have any other questions? Has that been what you wanted to know? Or, do we need to either answer some more questions now, or come back again to have a further consultation? Yeah, so... Yes, I think writing things down can be useful on a piece of paper, but of course everybody's got phones these days. You can write it in the notes app on your phone, can't you? And then you've got it handy, and you won't forget to leave it on the kitchen table, probably. Most people have their phones clamped in their hands, like I do most of the time. So what about headache diaries or symptom logs? I don't know if I'm overgeneralizing, but I find that there are some types of people that will like to bring in a multicolored spreadsheet, and that's often engineers, and they're very, very detailed graphs of what they've been doing. And other people will have written a little tiny bit in the corner of their paper diary, and everything in between. We have a downloadable diary on our website, the nationalmigrainecentre.org.uk, and we've made that quite definitely quite simple, quite purposely simple, because I think, speaking personally, to look at a month of a page, a page that just catalogues the pattern of those attacks, what the medication was that the person took, and whether there was anything significant, especially with women, like menstrual cycle, can be really, really helpful. But I'm also aware that there is a new app called My Headache, which you can download free, which I've been part of the team developing that. And that is something which we're hoping a lot of people will start to use, because its secondary purpose is to gather some anonymized data so that we can present UK data to policymakers and commissioners. How do you both feel? Surangi, how do you feel about symptom diaries?
Yeah, I really like them. I agree with what you're saying, Katie. It can be quite overwhelming just from the clinician's point of view if there's pages and pages of text. So what I usually say is it's quite helpful if I print it, it can be easily given to the patient. So just a month calendar on one sheet, or as you say, the one from the National Migraine Centre does the same thing. But if it's different boxes across the month, then I will usually try and say to people, look, if that's too overwhelming to try and fill that in, keep it by the side of the bed, and put a pen there, and literally just before you go to bed, write H for headache. If that was the day you had a headache, write D for dizziness, like write V for vertigo, or you could use colour, to highlight, green for headache and vice versa. And then likewise, we do want to know what medication you've taken as well. That, just keep it really simple, because if it's too overwhelming for us to read, it was probably quite overwhelming to keep it as well. Yeah. So we're thinking of the patient, of course. We don't want it to be a task. We don't want it to be a piece of homework. We don't want it to fill people with dread having to keep that diary. But it is crucial, because the headache frequency, particularly, as we've said right at the very beginning, determines access to these step-up medications. So actually, it's really important to have an idea, even a rough idea, of how frequent the headache is.
Lauren, what do you advise for children? Because, of course, we know a lot of kids have migraine, and it's really useful to know the impact and the frequency of their attacks too. Are there any different ways that you advise children to keep diaries?
Yeah, so I think depending on the child's age, obviously, it's really great if the child can get involved in the process too, because, if they do have a diagnosis of migraine, this could be a condition that they are managing throughout their life, and it's good to get them involved in that early. I try to go as simple as possible initially, really just to engender that confidence that they can do it, they can fill it in, and to support parents to not have to interpret too much about what the child is trying to describe. So I might initially say, let's do a traffic light system. So do a red dot on a day you have a really bad headache. So that might mean you had to miss school, you were vomiting, for example. An orange where you maybe had a moderate headache, so you could stay at school, but maybe you had to sit out of PE or something like that. And a green one where you had a headache in the background and you could carry on playing, or you managed to be with your friends for the rest of the day, and leave it blank where you had a free day. And then I just have a second column where they can write anything else. So with children, it might be tummy pain lasted 1 hour, 2 hours, or mum's noticed looked pale, or something like that. And I think that's a really good starting point, and starts to pull out some of the symptoms that allow us to make a diagnosis, particularly with our younger children, when it's really hard for them to describe what they might be experiencing.
I think you make a really good point about leaving it blank on a day when you have what we call a crystal clear head day, because I think it's as important to know the crystal clear head days. What people tend to do is they only mark down the really bad days. And I say to people, I want to know about all the days that you have any symptoms. But if it is a crystal clear head day and you feel 100% fine, leave that blank. And then that jumps out at you what the pattern is. So I think, yes, that's really, really helpful. And it can be a bit depressing if you're having to fill this in over and over and over again. I know I've done it myself in the past, and you think, oh, here we go again, another thing. But that's why the simplicity is easier, I think.
Yeah, and on the flip side, if you make it a visually impactful diary, actually, when you start to get people on the treatment that's working for them, or you detox from a medication that wasn't helping the headaches, it's amazing to sit with a patient and put 2 or 3 diaries side by side and see all the blank spaces or the green dots getting bigger and bigger and the red dots and the orange dots getting smaller and smaller.
Yeah.
And that is such a therapeutic thing, I think, just visually to see.
I think it's particularly important if you're going into the secondary care system or into specialist clinics, and you know the rules around eligibility for certain more of the newly discovered treatments depends on proving what number of days of headache you're having or symptoms you're having in the month, and so getting into the habit of doing that can be very, very helpful. Yeah. But if you haven't done it, I always say to people, they say, oh, I'm really sorry, I only just got the appointment and I didn't have time to do the headache diary. And I'm like, well, that doesn't matter. But, you know, let's just start doing something that might be useful going forward.
Yeah, definitely.
Yeah. And patterns can emerge, can't it? So if you're somebody, I've had this with a child, and he was having a recurring migraine attack, and they noted down that it was always the day after he'd had football practice in the evening after school, and he hadn't eaten enough, hadn't had his dinner, and then we were able to say, oh, this is a pattern that's emerged. And so, you know, it can be quite helpful if you're trying to be a migraine detective.
Yes, absolutely. And hormones and things like that, they often come out, don't they, after you've kept it for 3 months.
Definitely.
Katy, I was just going to say on that, in terms of how long to keep one for, I think, like you say, we've seen a wide variety of patients who come in front of us. And sometimes people, I mean, I saw someone recently who had kept literally years worth of a diary. And I think if you've got an appointment with secondary care, for example, that's a year away, I would say you probably don't need to keep it for a year, 18 months. Even if you kept it for 3 months ahead of the appointment, that's probably the most useful information. Like I said, we really want to get across that this shouldn't be a huge chore. It should be something that you're using just as to share information. So it doesn't need to be so long, really.
Yeah. If you haven't kept a diary, what I sometimes ask patients is, in the last month, how many crystal clear head days do you roughly think you had? How many days did you have an impact from your condition, which was an 8, 9, or 10 and wiped you out? And people can often give you an estimate, and it just kind of helps to clarify where you are now. And then you can say, well, how is that a different month from the 2 or 3 months before, or is that largely how you've been for a while? And sometimes they say, well, I can't remember when I last had a crystal clear head day, because it's been years, or, you know, so it's just, there's a lot of questions to ask when you see somebody for the first time, isn't there? So if they have the answers at their fingertips in a clear way, then that can be really helpful for us to get a very good picture of what they might want. And then we go on to talking about treatments, and ourselves as clinicians, we know what the wide range of treatments are, but it's very useful to know from the patient, what do you want the treatment to do? So do you want the treatment to quickly get rid of your symptoms? Or are you more interested in it getting rid of your symptoms so that they don't come back later on or the next day? Or what is it exactly that your treatment goal is? Do you want to have something that you can be really confident that it works effectively? Or do you want something that will suppress the frequency of the attacks over a longer period of time? So we tend to talk about treatments in terms of acute rescue treatments or preventative treatments, don't we? Do you want to say something about that, Lauren?
Yeah, so when we're thinking about options for you, we'll be considering whether you may need preventative treatments. And that's generally if you're looking at having 4 or more attacks a month, though there is definitely movement within that. And really the priorities that often are coming through for patients who are needing that's where they're saying, so many of my days are being impacted in a month that I'm starting to struggle with work, with, you know, short repeated absences. I'm struggling to manage my children in the evening. I'm looking for something that's going to reduce the number of days that I'm impacted by this condition, or I'm having to call in sick to work again because it's still there day 2, day 3. And pulling that information through, if that's really where we're looking to tackle first, is really helpful. If we're thinking about acute treatments, or all people who have migraines should be offered acute treatments, of course, but people might come to my clinic and say, oh, I'm absolutely fine taking ibuprofen, thank you, always have been, does the job, but I found that I can only take it a few times a week or in a month because I don't want medication overuse, and I'm finding that I'm having too many attacks that I can't treat because I can only take so much acute medicine. So that information is super helpful for me because, well, we've got information that you have an acute treatment that works, but your prevention probably needs to be a lot better. Or we need to think about alternative things you can do for your acute attacks. So I think as much information as you can give us about your priorities. For example, I've had patients who say, it's the rebound that gets me because it works really well the first time, but then if it comes back later, it just doesn't work again, and I've got it for 2 or 3 days after that. So it means we can tailor with our sort of bank of knowledge about what's available for you based on your medical conditions, etc. We can really tailor what we're offering from those 2 broad camps to be a sort of specific plan for you.
Surangi, what do you find with people who've tried the acute treatments like sumatriptan, and you get immediate relief, but then they have to go to sleep for 3, 4, or 5 hours? Have you come across those? I find this is quite a common problem, and people sometimes give up on treatments, don't they, without realizing that they can come back and ask again.
Absolutely, yeah. I think, and another kind of point on that is that obviously migraine changes through the lifetime. So what did work for you in your teenage years may be completely different to what then works, 20 years later. So it's an evolving, dynamic neurological condition. So, that's why there's always value in revisiting that. For those who take a medication and then still need the space to sleep after that, I think we would all say the same thing, that we would revisit what exactly we're giving and whether that needs to be combined with something else, an alternative. There are new acute treatments as well, or relatively new treatments such as the Gepant, Rimegepant, that you can use acutely, as well as atogepant is now being used acutely as of last month. So there's always ways to revisit what exactly we're giving. So if you're having to sleep, I just think, I always say to people, well, that's not quite what we expect to be happening. Really, it should abort the attack, and you should ideally be able to get on with your day, your life, your work. So we would revisit that, really.
And that applies to kids as well, doesn't it? It's very important that any child at school is allowed to take their medication quickly at the beginning of an attack, but hopefully not be sent home, because if we've got it right and they've got a good rescue treatment, then it works and they go back into the classroom, and the nausea's gone because we've given them an effective anti-sickness tablet. The pain's gone if they have pain, and that might be tummy pain or it might be headache pain, and their focus is back because the brain fog is clearing and they don't feel exhausted and tired from the medication. So it's a lot of things to discuss around starting some of these medications, to be warning people about what to watch out for, but also telling them, if it doesn't work, if it doesn't suit you, come back and let's have another discussion. So I've been saying this to several people recently. It's like, if you don't go and talk to a doctor and tell them how you feel, they will assume you are fine. Because if we don't hear from you again, we'll assume it's all worked. So do feel able to go back. And I think the other thing is, if you come across somebody where you have a consultation and it doesn't quite go according to plan, then it's quite reasonable to see if you can see somebody else. And is that possible in both of your experiences, that a second opinion or another GP or another expert could be involved?
Yeah, I think often patients are, and I've had this experience sort of through my own friends and family, when they've come to me after a consultation that didn't feel like it was helpful for them, and they feel very, very embarrassed, or like it's not an option at all to potentially go back and say, would I be able to see someone else, please? And I spend a lot of my time reassuring people that that's absolutely within your rights. And I would also prefer that as a clinician, if I wasn't able to meet your needs, that you were able to speak to someone who does. Because at the end of the day, we're all trying to achieve good care for our patients and keep them at the centre of things. So I explain it's absolute water off a duck's back to a GP practice if you need to ask to see someone else. And that also goes for if you feel more comfortable in yourself, say seeing a female clinician about migraine, say you feel uncomfortable talking about certain aspects, you're also able to ask for that up front. You know, it's absolutely fine to try and see someone who may better be able to meet your needs.
Yeah. Is that possible in the NHS secondary care service, Surangi, or do you think that's something that we're talking about in an ideal world and in reality that's quite a tricky thing?
I think it's entirely possible, definitely within my department, and we're certainly not keeping tabs on, everyone's busy, aren't they? So, we've all got our caseload and we're just moving through, trying to get through patients, trying to see as many people as possible and help as many as possible. So, as you say, if I would be mortified if someone felt that they didn't get what they wanted out of the appointment, but I know my administrative team are there to support the patient. I know because it's happened to me. Either a patient might want to see someone else within the team, and we're a big enough team to support that. Or I've been asked to see someone else's patient, and that's absolutely fine. There are various reasons. It might be something as simple as scheduling. It might be something to do with not gelling with the clinician, and that's absolutely fine. We are human at the end of the day, and we don't all gel with every single person in the world. So that's absolutely okay.
I think the other thing to flag up is that if you go to a GP and you want a referral, you have to bear in mind that there are some rules for GPs about what they're allowed to refer, whether they're allowed to, if you haven't tried some preventative medications, they may not actually be even allowed to refer you to a neurology department, or they may have to ask for advice and guidance. This is increasingly used, isn't it, where they can send details to somebody who is in the secondary care system, who will then send advice back saying, well, try this, try that. Is that what happens in your experience, Lauren?
Yeah, absolutely. So again, that information, if it's there up front, that's your expectation or your desire, that really helps me to go through your new journal entry or your notes and really check the eligibility criteria right before I see you, because it means we can have a really early, very clear conversation about what's going to be possible now and what may be possible later and the steps in between. Increasingly care, and within migraine, I think we all agree, the vast majority of migraine can and should be managed within our sort of primary care community settings where possible. And increasingly, there are GPs with specialist interests in various things. So GPs will often try to manage you in amongst their team. And that might be that I see you for your migraine care, but actually your menopause symptoms are really, really difficult. And I know I have a clinician in the practice who's a women's health specialist. So I may manage that side, and I may ask her to see you as a separate consultation. There may be elements of your care that I'm completely happy to manage, but there are one or two things that actually I think it would be really helpful for me to ask for some advice and guidance from a specialty about before I make decisions for migraine that might impact another one of your conditions. So I might write to endocrinology or another specialty, for example. So we will often try to manage you in practice, and what that isn't is gatekeeping or trying to stop you seeing someone. That's really just trying to make sure that you have had optimum primary care management, so that we don't waste your time sitting on a waiting list for a year for someone to send you straight back to us to do it all again.
Yeah, I think that's really important, isn't it? And also very conscious of the fact that we see quite a lot of people who have comorbidities. So they have other conditions which are highly linked with migraine. So that might be endometriosis or celiac disease or neurodiversity or anxiety and depression or other, mental health issues like bipolar. And we see a lot of people with hypermobility and Ehlers-Danlos who have other conditions linked with that, like POTS and mast cell activation syndrome, which we have done previous episodes on. So scroll back if you want to know more about those. So I think GPs are very well placed to be looking at the overview of all these interlinked conditions. But of course, if you are being referred and the local NHS service has a waiting list of, maybe 9 to 18 months, it varies around the country, this is a time to plug the NMC, the National Migraine Centre charity that we all work for, because you can always refer yourself to see one of our specialist doctors in the meantime. And often we can get involved and make a plan, discuss with you what is your priority, what you know, and you can take that report back to your GP and hopefully go forwards in managing your migraine better, even while you're waiting for the secondary care appointment to come through. So yes, that's just by going on our website, filling in the booking form online, and it will ask you a few questions, and then the team will jump into action. The other thing I was just going to say, of course, why now is a question. Why are you coming to see me now about this? And it might be that people have been managing their migraine okay, but they've decided to plan a pregnancy, or they need advice about contraception, or they're going through the perimenopause, they don't know whether they need HRT or whatever. So I think it's quite important, if there are particular factors as to why you have decided to have the appointment now, is to flag those up quite quickly.
Absolutely.
Yeah. So we're going, just one thing I was going to just mention. I sometimes say to people, ask the receptionist, is there anybody in the practice who gets migraine, who has a special interest in migraine? Because those are the doctors who will probably have done a lot of research, and maybe the ones who have a particular wish to help other people. That certainly was the case when I was in general practice. So we've talked about how to prepare. We're going to briefly talk now about at the first visit, and I've put at the top of my notes here, get the name of the person you're seeing and write it down, because I think it's really important to try and have continuity of care. And it is difficult these days, and we all recognise times have changed, particularly since COVID. But if you don't know who you've seen, you don't know what their name is, it's quite difficult to phone up and ask to see the same person. So I always say to people, get the name, write it down, and know who you're dealing with. Explain your top 3 concerns. We've talked about that, and present the information. And then, Lauren, we often, I don't know if you're the same, but I often say, right, I'm now going to tell you the exact diagnosis that I've made. I think that is important, don't you?
Yeah, absolutely. I'm the same. I always say that, and then I tell them it, and then we have a laugh about the fact that it's not a nice, short, succinct diagnosis. You have high frequency episodic migraine with and without aura, and they at least they have that information.
Yeah.
And I say to them, within, we know migraine doesn't have a cure. It's likely to be with you at some stage throughout your life, varying in intensity or severity and symptoms, and knowledge is power with migraine. And I think you can't gain knowledge if you don't know what you're researching or what material is relevant to you. So I completely agree with you. As soon as we have finished the history taking and the data gathering, my first port of call is a positive diagnosis. This is what I think you have based on this that we've talked about today, and here is what we can do about it.
Yeah. And we would all agree, headache is not a diagnosis. Dizziness is not a diagnosis. These are symptoms. So it shouldn't be coded as those. It should be coded as an actual diagnosis, of which headache, dizziness, brain fog, nausea, all of these are symptoms. We are going to talk a bit more in a minute about interpreters and language barriers and things. And some people say, oh, my husband's sitting in on the consultation, is that all right? And I'm always really happy if there is somebody else with a patient. And I think we'd all encourage that if somebody finds it helpful. Would you, I'm sure you have this, Surangi, in your practice.
Yeah, definitely. Particularly in secondary care, I'm not sure why it feels, because I know the difference. I should have said this actually at the beginning. I used to work in primary care actually before I came to secondary care. So I have a bit of an overview of both angles. And I definitely see a difference in secondary care. There's always a slight hesitation. So the patient will stand up when I call them from the waiting room, but then the spouse or the relative will stand at the back and they will always kind of sheepishly put their hand up and say, oh, is it okay to join? And I think it's absolutely brilliant when someone else joins, because we go into so much detail in these consultations. How can you possibly, even if you had a clear head, remember everything, all the details? So it's another pair of ears. Sometimes that person is an advocate. Sometimes people fill in parts of the history. It's so incredibly useful. From on the other side of things as well, I mean, the symptoms that patients are describing to us are often what we call hidden. So dizziness is hidden, headache is hidden. It's not like when you break your leg and you're wearing a plaster cast. Everyone, the whole world knows you've broken your leg. But all of these other symptoms we're describing, how can the spouse or the partner or the child possibly really get inside the head of the person who is, describing their problems? It's often very helpful. So much comes out in the consultation. The partner then truly has an understanding of what that person is going through. And it's often people walk away saying, yes, I really understand, what's going on. And it affects family dynamics, doesn't it? So for so many reasons, I love it when other people join in the consultation, if it's okay with the patient.
We've talked a lot about migraine, but I'm also very passionate about raising awareness about cluster headache. And I think, if you have somebody who comes in with their partner and they have witnessed that person in a cluster headache attack, not only can they give you really useful information about how they look or how they behave, but they can also get an understanding of the quite different approach that we use for cluster headache management, and how important and how seriously we take it, and how much, what they can do to help that person through an attack, which is sometimes just standing back, but I think it's something I'm very happy to do, is to have two people. What about taking a recording of the consultation?
Yeah, I personally quite like this for all the same reasons that I mentioned before. I think if someone is using it for their own information, to be able to listen back to or take parts out, or play it at a slower pace, because of course I actually speak quite fast and I'm trying to get through so much, particularly in an NHS appointment. That might be the one appointment I can offer that person for the year. So, I try and really put as much as we can in the consultation. So it's often really helpful if a person records it, if it's okay with that particular clinician, and also if it's been kind of put out there in advance. I have to say I've had it once or twice where people have been recording covertly, and I've picked up on it and I've said it's absolutely fine, but can we just have the recording implement out on the table, and it's all gone forward okay. But it's nice if you just ask permission in advance.
I think that's right. I think it is something that's generally thought to be helpful, but it's good to say it. If you want to record something, then make it out in the open, don't do it secretly, because it just feels a little bit more threatening somehow, or as if they're not trusting you or whatever. And of course it is a confidential place when you're having a consultation. So I think that goes two ways, that I think it's not something that we would like people to be having a recording and then putting it out on social media or something like that. I think they have to respect that this is a private conversation between the patient and their clinician. And of course, Lauren, if you're explaining something to somebody and they don't understand quite what you've said, it's fine for them to ask for you to explain it in a different way, isn't it?
Absolutely. I really like it when my patients say that, because I can remember that for next time, that, chunking it in that way or describing this thing in that way didn't really work for that person. If they're more of a visual learner or an audio learner, it means I can tailor what I'm going to subsequently give them, like signposting to things like the podcast or YouTube videos, because they don't like to read material, for example. It also means that we're utilising that appointment really well, because if I send you off with a plan that I think everyone has completely understood, and I see you in 3 months and you've been taking the medicine that you were meant to take every day just occasionally because I didn't make that clear enough, that's really, I've sort of failed you in that situation. So I much prefer you to say, sorry, you've given a lot of information. I'm a little bit confused about which one I'm taking every day, which one I'm taking just when I need it. Can you go over it again? I think we'd all prefer that than realise in 3 months that we've not really helped you in that 3 months.
And I think it's also quite often that we might seem to repeat our questions, don't you think, Surangi? Sometimes we might say, well, actually, can I just stop you there? Can I just drill down a bit more on what happened exactly when this started or whatever? And this is something that I think you highlighted to me that you like to do.
Yeah, definitely. And I think working, and I mean, we're going to come on to this next, but working with the populations that we see, particularly in inner city centres, often I will find patients come to their appointment and, I'm asking specifically about the headache frequency. And they'll say, oh no, it's just, something that happens quite frequently. I'll say, okay, but how often? Can you give me, for example, in a week, how many times? And always, without fail, people will know, even if they're estimating roughly how often that's happening. But what I suppose people don't realise is that is key information to allow us to elevate them to the next level of treatment. So, that's why I will press and I'll press again. And if people say they're not sure, I'll press again, or I'll get the if there's a relative there, I will say, look, can you have a discussion and try and work out, because this is crucial information. So yeah, it feels sometimes that sometimes we can go around in circles, but we're only doing it so that we can help take things forward.
I think that's also particularly helpful when somebody says, I know this started on the 25th of June in 2022 or whatever, and you go, oh, that's very specific. I'm going to ask you to think back on what exactly was happening and what were you doing, and having that kind of how it started information, if that is the story, is really useful for us to make the diagnosis, which may or may not be migraine, and maybe something a little bit more rare, like a CSF leak or something like that. Or obviously things like a head injury or, some intense family traumas or whatever. So we need to know a bit of background, don't we?
I think that's really true, Katie, because if you're thinking about the fact we don't have blood tests and scans that diagnose our primary headaches, really it is all in the questions that we're asking you. So if your GP or your clinician goes over ground again, goes back, starts to pick apart things again, the ones you were mentioning that week, they sounded a bit different to these ones. Can we now speak about both of these separately and go through all those questions again? Really what we're trying to do is that detective work to pull apart whether there is one diagnosis here, maybe two diagnoses here. And if we can't get that information, we're probably guesstimating your headache disorder. So yeah, we're not listening if we go over all ground or make you repeat things. It's really us trying to kind of go through a bit of a surgical sieve of options that are available to us.
Because some people do have two different headache diagnoses, don't they? So I've definitely seen a number of patients who come in with classical migraine symptoms. They've had those for maybe 10 or 20 years, and they say, oh, actually, now I'm getting these different headaches, and these are in a different presentation, and they turn out to have then developed cluster headache as well as having migraine. And that's not cluster migraine. Always, there's a real bugbear of ours, isn't it? There's no such thing as cluster migraine. So we will not be saying this is cluster migraine. We'll be either saying this is chronic or high frequency migraine, or this is cluster headache, or unfortunately, some people have both. But there's no such thing as cluster migraine. So if you've been told that, come and see us and we'll clarify. And then one of the things, obviously, towards the end of a consultation is to know what happens next. So is that it? Are you going away now back out into your life and you're not going to ever be seen again? Or are you coming back in 3 months or 6 months, or just if it gets worse? Or are you going to be seen again in a fortnight because you didn't quite get through everything? So having some idea of the follow-up, I think, is quite important, isn't it?
Yeah, absolutely.
Go on, Surangi.
Oh, okay. Yeah, so I think we need to know exactly what the plan is, and we want the patient to feel empowered to ask for a follow-up, or if the patient feels they need a bit of hand holding, or we need to know what the outcome was so that we can further the plan. It's very rare actually that we will say, here is the plan, and go off and implement that. Usually at some point someone will need to follow up for that patient. It might be us at the National Migraine Centre, it might be the GP, it might be the secondary care, but someone should be kind of usually overseeing that, unless you've got a very confident patient who says, yeah, I know exactly what I'm doing, I've had migraine for a very long time and I just came for this very specific thing. Then yes, but absolutely, we don't want anyone feeling like they're kind of left in limbo and not knowing what's next really, or when to come back.
I think, Lauren, that's particularly important, isn't it, when we've put somebody on a preventer, and if they're never followed up, they can be on that preventer for ages, years and years, and not been reviewed, and they probably don't need to take it anymore if things have settled down.
Yeah, absolutely. I see that through. So I obviously work within general GP, and then I work in a headache clinic. So I see GP referrals of people coming through to our headache clinic who have stayed on a very low dose of a migraine preventer for 2, maybe 3 years even. And you say, is that doing anything? Oh no, it's not really helpful, but they're still on it. And you go back into the history and they never really had a plan or an awareness that that medicine needed to go up and up and up on the dose to a dose that we think helps migraine. Yeah. So I'm very, very clear with my patients about, these are the points of our follow-up plan. This is who's going to do this bit. These are the bits I'm going to ask you to do. If this happens, I want you to send me another e-consult, because that's how we work with our practice, and directly address it to Dr. Wellburn, and it will get sent through to me and I can pick that up. And then I'm going to say, I'm going to put you in for a pharmacy follow-up call in X amount of weeks to make sure that you have gone up to this dose before I see you again in 6 months. So I'm as specific as that. And then I always am aware that that shopping list of bits and pieces is too much for anyone. To be honest, it's too much for me, even after the consultation, to remember to write down. So I always write it in a text to my patients, which I then send out. So they've got that record on their phone, or as Surangi was saying, if they've taken a recording, they can go back and listen to, right, what do I need to do? Or write up a piece of paper if they don't have a mobile.
Yeah. So it's really important before you leave the consultation, make sure that you're very clear about what the plan is, what the follow-up is, and really just what to do if things worsen. But also if things get better, you still need a follow-up to stop stuff. And I had a friend who was on something for about 15 years. And I said, oh, and when did you last have a migraine attack? And she said, oh, about 12 years ago. And she'd been on amitriptyline for 15 years, mostly unnecessarily. So yeah, I'm very aware of that. So we know that we're going to come on a bit to talking about problems that people might face. And we know that there are some problems within the NHS of getting access to appointments and getting access to treatments these days. Sometimes it's tricky with primary care, sometimes it's tricky with secondary care, with long waiting lists and things. And we're aware, certainly because we see patients from all over the UK, that there seems to be a bit of a postcode lottery for some things as well. We hear that patients can get access to things in one area of the country and are totally not able to get it in other areas of the country, because there simply aren't enough of us headache specialists, are there? We need more of us. So if any clinicians are listening to this who would be interested in training up, then get in touch with us at the National Migraine Centre, because we have a wonderful team and it's a very rewarding job to do. But I'm also aware that about 60% of people with migraine don't ask for help. And, sometimes you meet people socially and they say, oh, they always find out that I'm a migraine specialist doctor because I always talk about it all the time. And they say, oh, yes, I get this, but I have to go to bed for 3 days and it's terrible. And I'm like, well, have you sought help? And they go, well, no, not really. And I think we all want to urge anybody listening who knows somebody who's putting up with these horrible attacks. There's so much we can do to help. So get them to go and ask or come and see us at the National Migraine Centre. And one of the reasons for that, I think, is that there's some migraine myths and there are some misperceptions. Oh, it's just a bad headache. So Surangi, I know you work in well, both of you work in inner city clinics where you see a wide range of people from different backgrounds. and with a wide range of languages. Let's talk a bit about the barriers that can come up for people getting care.
Yeah, I think there's so many components to this. It's a struggle to know kind of where to start, really. One thing that Lauren and I have both definitely seen is that working within the populations in the settings that we work in, there is a disparity. I don't think we can kind of get around that between the patient who kind of comes super organized, everything that we've discussed at the very top of this podcast about, sending things in advance, sending all the letters, etc., and then a patient who, for a multitude of reasons, may not send things in advance, may not have English as a first language. I think, using the vocabulary, as we've said, is so incredibly important, particularly with dizziness and vertigo. To be able to describe something that is so abstract requires a certain level of, I'm not even going to say English. If we were in a different country, if I was trying to consult in my mother tongue, which is the Sri Lankan language, Sinhalese, I would struggle. So, I think we need to just kind of remember that and try. Things that have helped me, for example, if someone doesn't have English as a first language, of course, we always offer an interpreter. We have video interpreters at the hospital where I work. We would just wheel them in on an iPad. It's brilliant. They come up immediately. And that's happening live, dynamically. But actually, even if English is a second language, but they're fluent in English, sometimes it can be really nuanced. So, when someone says to me, "Oh, my eyes are turning," to me, that could be so many different things. And you just have to listen to that patient to really, and ask a few more questions. Is that nystagmus? So for me, nystagmus, is the movement of the eyes, a rhythmic movement of the eyes, or are they trying to describe blurred vision, or are they describing something completely different? So, that can take time. And, in an ideal world, what you want is a double consultation, or at least longer, with that patient, because even using an interpreter, of course, that takes time, because you have to send the information back and forth. So, we have to acknowledge all of these things, plus also, in terms of why someone might delay their care. Headache can become normalized. We all know this within the National Migraine Centre. Unfortunately, that phrase that we've heard so many times, "Oh, it's, just like the normal headaches."
Yeah.
And we all know that, we start smiling and we laugh now with the patient to say, there's no such thing as normal headache. Any headache has a cause and a reason, and that's why we do the work we do. So, that's just a kind of scratching the surface. Lauren, I don't know if you want to come in more in this area about why people delay.
Yeah, absolutely. I think so. For context, my practice is in what's called the top decile, so the 10% most deprived populations within the UK. And I think I've really noticed through my time working there that there are a number of reasons why people might not be able to do some of the things that we've suggested at the head of this podcast episode. And that could be they can't access the materials through, issues around literacy or writing or reading. That might be that they have significant caring responsibilities, are looking after multi-generational households with children and older relatives who depend on them, and they just do not have the time to prioritize themselves. It can be cultural ideals around sickness, showing sickness, whether that's a weakness or accessing treatments or some fear of kind of modern medicines and what I might be offering, and is that natural, and can they just get on with it? There are a number of different reasons that patients have expressed to me, when I have then found them in my consultation room and we have diagnosed migraine, that have meant that they've lived with this for decades, sometimes really disabling migraine, and haven't sought that help. And I think also when I've built rapport with patients and I've got to know them over a few appointments, some have also shared with me that they have felt unseen, unheard, dismissed. They have felt that there has been dismissal of things like pain based on their race or how they appear to the clinician seeing them. And I think as uncomfortable as those things are to hear as clinicians, hoping that we're treating everyone exactly the same, they're so important for us to be aware of, and aware of the fact that they're affecting our populations, because then we can start to think about reasonable steps we can make to make that less of an issue, to get people through our doors. So those are some of the things that I've sort of thought about in the few years that I've been at my practice.
I think the Migraine Trust did a very good survey, which they published in December 2025 and is on their website if anybody's interested to read that report. And that was a survey that flagged up quite a lot of these issues, and some quite scary stats from that, really. They found that there was a gender divide as well, that women were fearing being seen as emotional or unreliable if they disclosed migraine, and men were worried about being perceived as weak. So we're still finding these kind of really ingrained attitudes as part of the stigma around migraine as a condition, and the misunderstandings generally of society. Women described being told their migraine was hormonal or just part of being a woman. And, you know, we hear women talking about their symptoms every week now in clinic. And it's sad to me to hear that there are still these kind of phrases being bandied about. And the worst ones that, you know, will just wait till the menopause or go have a baby. And, you know, occasionally you do still hear that. Which puts people off seeking care. If they've been dismissed like that by one person, they may very well feel hesitant about going back again. And then ethnicity gaps in healthcare. Do you want to talk about that a little bit more? Because I think you both see quite a range of ethnicities and a huge number of different languages within your clinics. Do you want to talk about the stats for that, Lauren?
Yeah.
Or Surangi? Yeah.
Surangi, you go ahead, that's fine.
Surangi, go ahead.
Okay, yeah, no, I don't mind. So, yeah, we know that there are ethnicity gaps in accessing migraine care or headache care. So 23% of mixed ethnicity, 19% of Asian, and 16% of Black respondents to that survey said their ethnicity had negatively affected their care, versus just 7% of white participants in the survey. And I think, as Lauren has touched upon, there are so many different aspects to why this is the case. Just anecdotally, I would say that I have seen a number of patients now who have been at the end of their consultation with me or a member of my team and have said, yes, you know, for the first time we felt heard or listened to. Mm-hmm. And that does not fill me with pride or joy. That tells me that somewhere along the line, well, multiple times along the line, they've not been heard. Yeah. And then, as you know, as we said, this just contributes to delayed presentations. And then they've, you know, and it has there's a societal impact on this. If you cannot work, if you cannot do your duty as a parent, if you cannot do, you know, provide caring responsibilities to the people, you know, your parents, it's a societal problem, really. So yeah, this is quite frustrating and upsetting, actually, I have to say, to hear this kind of comment. People from ethnic minorities are also describing being ignored or disbelieved or stereotyped, and this kind of transcends not just headache care. We know that there are studies that have happened, big pieces of work that have been done in maternity services for Black and ethnic minority women that have shown disparities, huge disparities in the care that's provided. And it's nice that this is actually being looked at, that the Migraine Trust did this work to try to bring this out, because we know anecdotally that these things are happening, and we really need the data to be able to shape how we might then start to change this and actually open up the conversation about this, because it's, unless we kind of talk about these things, that's the only way to kind of really move forward, to acknowledge them to start with.
I think the awareness of this happening is the first step, isn't it? And there are changes that need to happen, but first of all, we need to recognise that it is happening. And this can be happening in the workplace as well, can't it? That You know, a lot of people don't want to disclose that they have migraine to their employers because they're worried that they're going to be judged or that they're going to be thought of as swinging the lead or being lazy or whatever because of the misconceptions about the impact of migraine. But in the study, I was interested to see that it said 26% of white respondents felt that they were worried about workplace discrimination, but 37% of Black respondents were fearful about that. That's really a significant thing, isn't it?
It is stark. And I mean, we hear about worry around speaking to work about, you know, the type of discrimination that can occur when you have migraine through work. And I think when you're considering that in our kind of a population that might be most affected by health inequity, there's probably a higher proportion of people on things like 0-hour contracts that are also then much more vulnerable to periods of no financial income. We can't offer them sick notes because they cannot take time off work. So you can really see the ripple effects through every aspect of life, you know, right from the fact that we don't have brilliant research on women. We don't have huge amounts of people from Black and ethnic minority groups within the studies for the big pharma companies. You know, this is really far reaching, and I think it has to be discussed, and people have to sit with the discomfort and do a bit of sort of soul searching about what we as clinicians can do, whilst being aware that a lot of this are systemic problems as well.
A much higher percentage of lower income respondents in that survey were pushing themselves to work through a migraine attack. So I think it was 49% were working through a migraine attack, rather than 33% of higher income respondents. And that again is, you know, this myth that people with migraine attacks are just trying to have a sneaky day off, whereas actually most people with migraine are pushing through and going to work when they probably shouldn't be. And presenteeism is a major cause of impact on our economy as a whole, because people are going into work and performing not at their best, when they should be resting up and treating their migraine attacks. I think we've all heard of people doing that. So there's also, we were talking just before the recording started about health literacy, and that kind of basically means, are we providing health education at a level that most people in the country can understand? And we were talking about some figures of, you know, the average reading age that we should be preparing information in is for somebody who has a reading age between about 9 and 11, I think we said. Lauren, do you want to talk about how are we tackling that enough? What can we do about that?
I think we're probably not tackling it enough. I can't speak for the big guidance documents, you know, the NHS website and patient.co.uk and these sorts of places, whether they are putting their text, their copyright through, you know, AI or whatever to try and make easy read versions or things like that for their patients. But I'm certainly aware that I have a bank of things that I use, and I try to tailor that to people. So if people aren't going to be able to read a big chunk of text, I try and provide things that are easier to read, or I provide audio media or visual media instead. But we probably can and should be doing more, really, to make information for a variety of people completely accessible, even without them having to ask specifically, because a lot of people feel a lot of internal shame around not being able to access text in the way that they feel, you know, or the government states that we should be by the end of primary school, for example.
On that note, Katie and Lauren, I was just going to say, actually, within the trust that I work for, we've got they're starting to use an AI tool now to try to make information in easy read format, because I can say from our side, from secondary care, if we're writing a patient information leaflet, there is a kind of overarching requirement to try and make it written in a way that is accessible, but there isn't a kind of, to be honest, this whole reading age of 9 to 12 or 9 to 11, you know, that's not explicitly stated to us. So if it's not explicitly stated like that, then I think, you know, that's very difficult for, let's be honest about who's writing these patient information leaflets. We're all, you know, we're university level educated to a certain, by definition, to be practicing in doing the job we do. So actually reversing that and making it accessible is really important. It might not be something that's easy to do, but there are tools being developed now to try to facilitate that. And it's so important, to try and make sure that people, because as you said, no patient is ever going to turn around usually and say, I cannot read that or I cannot access that. So it's up to us to think about the populations we serve and where we work, and think about whether the information that we're providing is given in the correct format for that particular patient.
I mean, this is where, although a lot of people are a bit scared of AI, this is where AI may become absolutely fantastically helpful. And there are other tools, not just AI, aren't there? I mean, there are a lot of translation tools now. And I was checking out the Migraine Trust website, and they've got a very clear list of translators that they suggest people look at, where you can, copy a body of text, maybe the transcript from this podcast, put it into either Google Translate, Microsoft Translator, Bing Translator, DeepL, or Reverso. I have to say I don't have any shares in any of those. I don't know if one of those is better than any of the others, but there are ways now. And then, of course, from an accessibility point of view, there are also tools that will read stuff out for you. So if you're not able to read it yourself, then you can press a button and it will read out the audio for you. So I think it's something we all as clinicians have to be aware of, isn't it? That we need to be sharing the information in an accessible way. And hopefully as time goes forward, there are increasing numbers of ways that we can do this. So I think we're coming to the end of this episode. I think we've covered a lot of ground. And is there anything, Lauren, that you think that we haven't said that we need to just say now? Any other particular points you wanted to make?
I think it's really for anyone listening to this podcast. So we know that people listening to this podcast may not be listening if they don't have English as their first language or second language. So if you are listening to the podcast today, or you're working in a community similar to those that Surangi and I work in, or even any community within the UK, because we're such a heterogeneous society as we should be these days, really, I would just ask people to reflect on whether there's someone they know, a relative, a friend, who might benefit from being supported at an appointment and opening some of these conversations, because we are here to have them and we do want to have them with you. And if the clinicians are listening, really to just go back to your practice and think, because each practice is very different, where are some changes I can make? And even if it's just one step, that may massively make a difference to a huge subset of your patients. So that would be my main message from today, I think.
And Surangi, any final points that you'd like to make?
Probably my only point is that, taking a personal slant on this, I said to both of you ahead of this podcast, I'm a second generation immigrant myself. So my parents came to this country a long time ago. And I watched my own mother through her menstruating years. She didn't say she had migraine, but now I look back, obviously doing the job that I do, and I think that, I remember her out of action for several days at a time, probably around her period actually, where she was just incapacitated and not able to fulfill her caring responsibilities. There would have been multiple reasons for that particular person for why she didn't want to access care. Maybe she didn't know, in those days, access to even the medications that we have access to now, that wasn't, things have moved on basically. But that is the point, I think, of this podcast, that things have moved on. We want people who have traditionally probably not come forward to really hear that there is so much that can be done. We are helping a lot of people through the National Migraine Centre, and we want to just make sure that this care is accessible to everybody, because there are some communities we know we're not reaching, and we do really want to reach as many people as possible.
Yeah, and just to finally say, if you are listening and you have any thoughts or comments about this, we're very happy to take that on board as a team. So emailing info@nationalmigrainecentre.org.uk, if you have any suggestions about how we can improve, how we can work on all of the things that we've discussed, I think we'd be very happy to hear them, and we'll discuss those as a team of admin and clinicians who are all absolutely dedicated to try and improve the service that we provide and to spread the word out there in society generally about how much help there is available for people who have these recurring headache or migraine attacks. So thank you both very much for coming on the podcast today. It's been absolutely brilliant to talk through these issues, and it helps us, I think, to raise our own awareness, about what kind of things we should be thinking about. We haven't mentioned in this episode people with learning disabilities or neurodiversity, and I'm very hopeful that soon I'll be doing an episode with another of our colleagues who has a special interest in this area. So we'll be tackling that, and listen out for that podcast coming soon. So thank you once again.
Thanks very much.
Thank you for listening to the Heads Up podcast. Visit our website to book your appointment with a world-class headache doctor wherever you are in the UK. There is no need for a referral. You can refer yourself. Our headache specialist doctors are looking forward to helping you soon.